Welcome to the Memorial Day edition of AMA. So, a lot of good questions today. Hope you guys are enjoying the holiday. I actually spent it doing some hiking over in the Shaw Nature Reserve, which is always a favorite place to go in the springtime. So, a little bit of nature bathing today. So, hope you guys did something worthwhile. Good questions tonight. So, we'll get started. So question one, how are heart palpitations different from or related to atrial fibrillation? So heart palpitations is, a broad term. So palpitations can either, describe skipping beats, rapid beats, missing beats. It's just an abnormal sensation that you sense in your heart, usually due to an electrical imbalance. Atrial fibrillation is one arrhythmia that some patients will describe as a palpitation, where they'll feel their heart being irregular, but many people do not feel atrial fibrillation. So palpitations, can be benign. There can be some ones that are a little bit more malignant, but a history, a physical exam, often an electrocardiogram, Holter monitor, which records your heart rhythm for 24 hours or longer, and potentially an echocardiogram to look at the structure of the heart, kind of figure out why you're having heart palpitations and if it's atrial fibrillation or not. Question about niacin. So what about high dose niacin for lowering lipoprotein a? Not a lot of data that it actually has much benefit. May lower lipoprotein A 10%, maybe 15%. Possibly, I think I've seen as high as 20%, but is that clinically beneficial? Nobody's ever actually been demonstrating that. So it's kind of fallen out of favor. I personally don't recommend it very often. If people come in on niacin for it, I don't necessarily stop it, but there's some potential side effects with niacin. Can raise your blood sugar. To get the doses that you need to really lower LPLA, you're often getting to 1,500 milligrams, 2,000 milligrams a day, and often people can't tolerate the flushing with niacin at that dose. So a little bit challenging to use for LPLA. So right now, if somebody wants to use a drug to lower it, it's going to be the PCSK9 inhibitors. The only really approved therapies that lower it significantly, meaning like 90% or more, it's going to be apheresis, which is kind of like a dialysis for your blood. But the antisense oligonucleotides and the small interfering RNA molecules, they're going to be out in a year or two, and they're going to take care of LPA. So, what are my thoughts regarding the health benefits of L-Arginine and the Nattokinase? So, take the Nattokinase first. So, Nattokinase can help break up fibrinogen. So, usually talk about this with patients that fibrinogen makes your blood sticky like ketchup. So, Natto can make it, flow more like red wine. There is some data that very high dose of nattokinase may help with atherosclerosis regression, but that needs to be repeated in size before I'd routinely recommend it to people. And then L-Arginine is an amino acid that usually is not in short supply, so you don't necessarily need to supplement with L-Arginine. The problem for most people is that their endothelial nitric oxide synthase enzyme isn't as functioning as it once was, and it won't convert the arginine in the presence of oxygen over to L-citrulline and nitric oxide. So most time you do not necessarily need to be supplementing with L-Arginine. You need to work on ENOS. Somebody's reporting that they're going for a CT coronary calcium scan after a possibly abnormal stress test, EKG. Anything also recommended. So this would actually be unusual and not the recommended use case for a CT calcium test. The CT coronary calcium test is a risk stratifier. It will not tell you about degree of stenosis in your arteries. So if somebody has an abnormal stress test, EKG, and depending on why they got the stress test to begin with, a better test would be a CT coronary angiogram, where they would actually look for the degree of stenosis in the coronary arteries. But that being said, a CT coronary calcium scan of 0 would generally indicate a low-risk study, but up to 10% of people can still have relatively significant soft plaque in their arteries that could cause an abnormal stress test. So having a calcium score of 0 not necessarily get you out of the the danger zone if you're having symptoms that led you to getting the stress test in the first place. There's a question about functional versus allopathic medicines, similarities, differences, pluses, minuses. So I'm a conventionally trained cardiologist, board certified still. My training after college included 4 years of allopathic medical school, so I am an MD from the St. Louis University School of Medicine. Then had to do a 3-year internal medicine residency. Then did 4 years as an internist for the U.S. Navy. Then did 3 years of cardiovascular disease, and then went out into private practice. So I've been a physician for almost 22 years. At some point, I got more interested in the preventive side of medicine than treating people with just pills and procedures. Functional medicine is not a, course of training that you do, out of college. It's something you do after you've had traditional training for the most part. And it is somewhat of more of a marketing term because there is no, credentialing to be functional medicine trained. Two of the bigger organizations, the IFM, the Institute for Functional Medicine, and the American Academy of Anti-Aging Medicine, or A4M, offer lots of training courses for people to get training in functional medicine, which is getting to the root causes of diseases and looking at systems bases more than just disease bases. But there are some programs like University of Arizona has a functional medicine fellowship, but that's basically only offered after you've done conventional training. Functional medicine is a good starting point. It's looking much more at lifestyle than allopathic medicine does. Stress management, sleep, nutrition, exercise. But sometimes the knock on functional medicine is that they're just replacing prescription medications for supplements, and they're doing a lot of expensive lab testing, which may or may not actually change the course of action or the health span of the individual. So I use some of the tools of functional medicine, but I don't consider myself a functional medicine practitioner. I've learned other techniques. The biohacking world was informative to kind of put me on the right path for quantum health. So I found the Quantum Biology Collective, Dr. Jack Cruz and such, and learned about mitochondrial health. I think functional medicine is a good starting point for some people, but be careful. Somebody's just saying that they're a functional medicine provider. You have to really vet where are their credentials. I'm still a board certified cardiologist with 22 years of experience. So it is make sure you're vetting the people who are giving you recommendations. What do I think of easy water, or what's also known as exclusion zone water? It's the fourth phase of water that Gerald Pollack would describe. It's the one who's has the basically the way to describe it is an exclusion zone that is a gel-like surface, or I should say a gel-like water phase of water. Gerald Pollack's book is called The Fourth Phase of Water because of that. So if you want a good intro to the topic, look at Gerald Pollack's work. But your lining of your arteries, the glycocalyx is heavily populated by easy water. So if you have a healthy glycocalyx, you have healthy arteries. So you have to mind your exclusion zone. So this is where grounding and earthing is beneficial. This is where getting infrared light and UV light on your surfaces helps structure the water. And the molecular hydrogen in your water, that's debatable. Depends on how the molecular hydrogen is obtained. You do not know, if you're dropping tabs of magnesium into your water, are you actually introducing deuterium into your water and potentially causing issues with your mitochondria? But if you can get a clean source of molecular hydrogen, it's a selective antioxidant, may be beneficial for mitochondrial reactive oxygen species being quenched. But easy water, definitely important. Molecular hydrogen, just be mindful that you need to be careful of where you'd be getting the sources of molecular hydrogen. There's a new trend to drink hydrogen water for wellness. What's my opinion? So there's a difference between hydrogen water, where there's molecular hydrogen gas inside the water, and then the alkaline water, which that's what's causing it to be high pH. So I don't think it's necessary to drink alkalized water. The machines that make the alkalized water, probably the benefit is that it's making molecular hydrogen in the water. So personally, I just recommend people avoid tap water so that they're avoiding fluoride, they're avoiding microplastics, they're avoiding heavy metals. So, don't drink tap water. You need to filter the water. So ideally through like an reverse osmosis filter or potentially a Berkey filter. I personally, for drinking water, like spring water. So I have 5-gallon glass jugs of Mountain Valley spring water delivered to my place, and then I just drag them around in metal containers. Next question, for what types of patients do I typically recommend a CT angiogram / Clearly? So Clearly is a AI machine learning algorithm that interprets the CT coronary angiogram images and voxel by voxel, looks at the walls of the artery to quantify the degree of plaque that you have in your artery wall. So think of your artery as like a garden hose, and they're taking slices through it. How much of the garden hose actually has plaque in it versus where the water would be flowing, the lumen. Now, this is kind of a moving target. I used to say, the CT angiogram probably should not be done young people under the age of 40, but if you have a very strong family history or somebody in your family having vascular disease under the age of 55, I have seen somebody, in their mid-30s getting these scans before, but that would be kind of a very one-off type of assessment, and definitely has to be individualized because, the amount of radiation is not trivial. You want to minimize your lifetime dose of radiation. So that's why this should not be a scan people at 18 should be starting, because the odds that they'd have significant plaque in the arteries at that time is very low, unless they have something like familial hyperlipidemia. So in all comers, probably still would say around 40 would be a reasonable time to consider it. But that would be talking to your doctors to figure out you're a good candidate. Do you have normal kidney function? Maybe you had previous issues with contrast. Can you safely take a beta blocker, such as you don't have asthma. So there is some nuances to getting this test, but it is the best non-invasive test, in my opinion, at quantifying people's risk from a vascular event. Plaque is common. If people live long enough, almost everybody will develop some degree of plaque in their arteries, but most people will remain asymptomatic their entire life, and it's the total plaque volume that predicts risk. The more plaque, more risk that one of those plaques ruptures and the person has a heart attack. So I think it is helpful to get these type of tests, but you do have to be mindful of a couple things. Question about NAD IVs for heart health. Haven't seen a lot of great data behind it. Nobody really knows if the NAD actually gets into the mitochondria in the heart and actually increases the NAD levels at the first cytochrome. And I've not personally ever done IV NAD. Just from hearing people's experiences with it, tends to make you very nauseous. And unless it was something that you could actually quantify and say like, hey, I feel amazing after this, and I've exercise capacity went up, okay, but I think there's other lower hanging fruit to work on. So are you sleeping 7.5 to 8 hours a night? Are you getting proper sun exposure? Those would be better things to consider than doing NAD, in my opinion. All right, so somebody's asking me my opinion on a study showing fish oil may increase the risk of first-time strokes and atrial fibrillation among healthy. I'd have to see the actual article to be able to comment more intelligently on it, but my standing kind of orders with patients is that I want them to be eating the seafood. I don't want them to be supplementing it, because you have too many variables when you take a supplement. You don't always know how well it's been processed. You don't know if it has contaminants in it, PCBs, heavy metals. Some of the better brands are definitely tested and don't have those things. So I'd have to know exactly what they were taking and what other things they had going on. But if you do take something that is supplemented and it's oxidized, then it's going to cause more inflammation in those individuals and potentially cause more concerns downstream. So, I personally don't take fish oil supplements. I don't tend to recommend it a lot to my patients unless they have a lot of inflammation and there's a very nuanced case and there's a reason that they can't be getting it through their diet. What are my thoughts on the old school approach of using released niacin? I assume it means time-released niacin. niacin to be effective, it has to be the full flush variety for at least a lipid lowering effect. People are using niacin for liver detoxes, or it's helping with sweating while they're in the sauna. That's a different approach. But I answered a question earlier about using niacin for Lp(a). I tend not to recommend it. Not a lot of data that it lowers events. So we're about lowering events, not just making labs look pretty. And then definitely no reason to use niacin to raise HDL. It's completely debunked that you should be trying to raise HDL through any type of pharmaceutical or nutraceutical approach. It's just more complicated. What is the function of HDL? Way more important than the total number of HDL particles. So there's no such thing as good cholesterol, and trying to use a supplement to raise HDL has not been proven to be beneficial. So don't tend to use a lot of niacin these days. Some people, if they have, let's say triglycerides over 150, metabolic syndrome, can't get triglycerides down through lifestyle changes, sometimes they'll still reach for niacin, but not very often. All right. So I think I got through the pre-populated questions. All right, so somebody's asking about supplements. What are my thoughts on Endocalyx Pro versus Artericell? There are two products that can help support the endothelial glycocalyx. Full disclosure, I am a speaker at times for Artericell. It depends on who you're working with, who's going to recommend one over the other. I just have more experience with Artericell. I have some of the devices that they use to study their product, including the Max Pulse. So I can kind of replicate some of their studies with my own devices in my office. So that's the reason I use it. The backstory is that the same gentleman basically developed both products. He sold one of the products off to a company called Calroy that became Artericell, and then he started a company that became Endocalyx Pro. So same gentleman developed both products. And then somebody's asking me about NR. It's basically a precursor to NAD. Same story. Unknown if it gets into the mitochondria. If you can have a kind of feature where you can say, hey, I feel way better with this. I exercise easier. Okay. But there's not a lab that you're going to be able to point to, or any type of imaging test you can say that this stuff's getting into where it needs to be, or that you're getting a benefit from it. So I tend not to use a lot of it. Somebody's asking me about my thoughts on the colostrum supplement. I don't have any experience recommending it. Somebody says, is there a new medicine that can help boost HDL? They have Lp(a). They're still working on some of the CETP inhibitors, but those original studies with them actually showed patients had more cardiovascular events, including death, when they raised HDL with the CETP inhibitors. The newer one, may have more benefit because it's going to be more, beneficial. In my initial understanding, this can be lowering ApoB more. I don't think I've seen it have any effect on Lp(a). Those are the antisense oligonucleotides and the small interfering RNAs that'll be out for Lp(a). So it's much more, like I said, function about the HDL than it is the total number. So initially just focus on getting your LDL side of the equation down, is usually what I tell patients. So ApoB is under 70 for most people. All right. Well, I think I got through the questions here. If any more pop up, I'll answer them. But we're going to do this again next Monday, 6 p.m. Central Time. I'm working on a couple videos for my YouTube channel, which is just drtwyman.tv. Goes to my channel. I did record a video about how to interpret labs. They're my labs. I recently got another set. I'll probably do another kind of a follow video in that in a couple weeks. And then I'll also likely put up a video on my Clearly scan. I have a couple people I got to review it with first, and then when I have a little bit more data, I'll share with you. But I can give you the backstory is that I did shrink some of my plaque by at least 6% in a 2-year period without taking any pharmaceutical agents. I did everything I needed to do to optimize nitric oxide, support the endothelial glycocalyx, and did modulated lipoproteins with a couple different supplement options. But now I'm going to be a little bit more aggressive and then repeat another clearly in a couple years and continue to show you that I can keep getting the plaque to shrink. So I think there's one other question I'll answer just in a moment here. But if there's topics that you want me to be able to kind of share either on YouTube or maybe even do another kind of IG live where we just talk about one topic, I'll put a link in my story after this. It's a quick 5 question poll. And it says what do you want to learn more about? And then a couple of little questions. This helps me know kind of how to help create content for you guys. So let's see, one last question here. Somebody's saying that the ApoB is down at 33 from 190. That's a pretty significant drop. That's awesome. They were using Repatha, which is a PCSK9 inhibitor, Livalo, which is a statin, and ezetimibe, which is a cholesterol reabsorption inhibitor. The person stopped the statin and the ezetimibe, about to test after 90 days, not on. About to test after 90 days. I don't know what not Repatha means. But 65 years old, they got a calcium score of 97. Where should ApoB be? As low as tolerated. There's no unsafe level of ApoB. I have family members with ApoBs in their 40s on no medications because they have loss of function PCSK9 genes. So they basically have built-in Repatha. So, depends on the backstory, of course, but, calcium score under 100 is not excessively high risk. So would probably shoot for at least an ApoB less than 70, but optimally less than 55. That puts you at the 5th percentile. So I wouldn't back off on the treatments unless you're having side effects or you have suppressed desmosterol. If you have suppressed desmosterol, there's some concerns that there can be some neurological issues, and you can get the desmosterol level on a cholesterol balance test. That's done through the Boston Heart Diagnostics Lab. Or there's a home kit where you can do it with Empower DX Labs. It's a finger stick, and I did that a couple weeks ago, and I wasn't a hyperproducer or hyperabsorber sterols, so that helped inform me how I'm going to best treat my ApoB particles. Oh, Repatha. Okay, got it. All right, guys. Well, I hope you guys have a rest of the Memorial Day good time, and I'll be back next Monday. So take care.